We're going to start off. We're going to start off with a WestCare Pacific Islands overview. So we'll talk about the history. We'll highlight all of our different programs, and then we'll go into the school-based services, which is offered by the Youth Behavioral Health Program, and then we'll move into the community-based services portion, and then just end with some next steps. Next slide, please. And so these are your presenters. It's myself and my colleague, Asia Ramos, who is also our Senior Vice President of WestCare. So I'll go ahead and start with introductions. I know that there was a little bit of a description of the presenters today. And so Asia and I just wanted to be able to take the opportunity to talk to those who may not know us, but also talk about our journey as we became social workers. So I can start with myself. My name is Beverlyn Coleman. My maiden name is Chargaloff. I was raised in the village of Inarahan. I attended Inarahan Elementary, Inarahan High School, and then I made the decision to attend Notre Dame High School, where I graduated in 1996. From that, I went and attended the University of Guam with a short stint at UH Manoa, but the short stint that I had in Hawaii was the pivotal point in where I decided that I wanted to be a social worker. For any of the students that are in here that are in the social work program at UOG, I'm sure, as all of us have, kind of struggled with what we wanted to do, what we wanted to major in, and those kinds of things. And I was just that person. I was that student. I knew I didn't want to do anything accounting, business, science, anything like that. That was not my strength. But I knew that I wanted to do something where I could help people, but I just didn't know what my options were. So I had taken a sociology class, I had taken a psychology class, and I was like, okay, well, that's kind of it, but it's not yet where I want to be. I took a criminology class, and I was like, no, that's probably not really my thing. And then I was at UH and I saw a class that said Intro to Social Work. So I was like, Intro to Social Work, let me go ahead and try that. And the very first day that I sat there and learned about social work and what it was, I knew that that's exactly what I was looking for and exactly where I needed to be. So when I transferred back to the University of Guam, I came in, I declared my major, and I was in the social work program. So I graduated with my bachelor's degree in social work in 2001. So I'm just giving away my age now. And then I moved to San Diego, and I was a residential aide at a adolescent group home for teenage girls. So it was a transitional home. So for whatever reason, they were in a foster placement. That placement broke down, and then they were in the residential home where I was at until there was another transitional home they could find. Also, I worked in an after-school program for kids with autism, and so that kind of just helped me see how much I could do with the degree that I had. I ultimately returned home. My father passed away, and so I decided that Guam was where I needed to be, and I needed to be with my family. And then I took a bit of a break, and then I decided, okay, I'm ready now to get back into the profession. So in 2004, from 2004 to 2011, I was a social worker at special education under the emotional disability. So my supervisor is Tom Babauta, and then just a little note, when I was an undergrad student, I did my practicum there, and my field instructor was Dr. Trisha Lazama. So just kind of giving any of the students in here an idea of how, when you make those connections in your undergrad, how that really benefits you when you're ready to go into the world. So I was a social worker too there for about 7 years. And then I joined the Army National Guard, and I relocated to the States, where I continued to do work. I was a residential counselor at a pseudo basic training residential home or facility for kids who were not able to really make it anymore in their school, and so they were just pursuing their GED instead of their diploma. And then I was in the early intervention program in Colorado. And then in Washington State, I was a transition counselor for service members who were getting out of the military, whether they were retiring or they fulfilled their time and they wanted to do something different. I came back home in 2019 because my husband was going to be stationed in Korea, where I was the program manager for the Ali shelter with Catholic Social Services. And then I ultimately ended up here at WestCare Pacific Islands, working hand in hand with our amazing Senior Vice President Asia and just getting a program started from the ground up. And so that's kind of been my journey, and this is where I'm at now. I did get my master's degree in mental health counseling also from the University of Guam, and that was in 2010. So I'm a true Triton, and I'm a true product of VOG. So that's basically my journey. This is where I am, and I'm going to go ahead and hand it over to Asia.
Thank you, Bev. I reiterate the same excitement to be here today amongst my fellow social workers who are out there every day giving so much of themselves for our community. When I reflect back on how I got started in social work, many of you can probably relate. My introduction to social work, I think, really stemmed from my family. I come from a very long line of public servants who dedicated their lives to the betterment of people of Guam. I think when I recall my upbringing being in that family setting and amongst my friends, I remember, as I'm sure many of you, always being sort of that go-to person for people and problem solving and just being the ear and the shoulder to cry on. And so I've always had an affinity for compassion and empathy and listening. So it only made sense that I would dedicate my career to helping others. And I remember the moment, in college as I was getting ready to graduate, and with conviction, I was going to be a social worker after, exploring various different fields and interests. And I distinctly recall telling my grandmother, "Grandma, I'm going to major in social work." And I was so excited. And she looked at me kind of disappointed and said, "Ay, Nen, you're not going to make any money." And I said, "Okay, Grandma, but I'll be helping others." And the irony in that whole situation was that my grandmother is actually a renowned public servant. Her name is Dr. Catherine Uggan. She was a pioneering Chamorro woman, the first Chamorro woman to earn her PhD at Berkeley. She was an educator, a former director of education, a leader, and the first female vice speaker of the 14th and 15th Guam legislature. And she dedicated her life to elevating the social conditions of our island and our people. She was a driving force in an array of policies that included the preservation of the Chamorro culture and language and the advancement of education, which included the public law, which establishes the Guam Community College. So here my grandma was with all of these accomplishments that were really dedicated to social justice and advancing our people and our island, telling me that I wasn't going to make any money and being just a tad bit disappointed. But where I stand today, I know she's really happy and proud of the work that's been done. I've been in the field for roughly 20 years. My educational history really started in the city of Seattle, where my work history also lies. In 1997, I graduated from Academy of Our Lady and moved to Seattle, Washington to attend Seattle University. I majored in what was called applied sociology because we did not have a BSW program at the time. Coming out of my undergrad, I worked in a residential treatment program for youth. And these were youth who were in the foster care system who had high levels of acuity, who needed assessment for mental health, who needed behavior management, and lived in a therapeutic milieu as they stabilized their behaviors. If you wanted to get into the field and just dive in head first, this was that kind of placement. It taught me so much about mental health, about children's services, and about the impact that we can have on our clients. After that, I moved into the position of a children's advocate, working in a transitional program for homeless individuals. I worked to really build a program specifically in the transitional housing that served children who were in need and who were challenged with the different transitions in their lives. I worked closely with schools and with families to come up with case plans and treatment plans and individual groups that really helped our children get to where they needed to be while they were in that temporary housing placement. After DID, I did a short stint in California, which interesting work. I worked in a home-based early Head Start program, mostly with Latino, immigrant, undocumented families. And I feel so privileged and fortunate to have witnessed many of their stories and challenges of coming to the US and the conditions that they faced as undocumented individuals. And so my sense for social justice just really increased in working with that population. At the time, I began to feel that I wanted to advance my education and really get into a clinical track. I applied and was accepted to the University of Washington Master of Social Work program, and I graduated in 2006. Upon graduating, I was really feeling like I'm going to become a community organizer, but ended up in this mental health field, which I think was actually exactly where I needed to be. I worked for a community-based organization, which is the largest organization in the King County area in Washington State at the time, around mental health. I was one of the care coordinators in a clinical position in a school-based program, which we'll talk about today. That was really the impetus for our program here with Malik Naha'ani, and we'll get into the details of what that looked like. After that piece, I transitioned to become a wraparound facilitator, also employing clinical skills, kind of had a dual role in providing clinical therapeutic support while also providing facilitation. I then moved on to be the supervisor of that program shortly before I came home. Now, my journey home is, I think some of us who were born and raised in Guam and become part of diaspora feel this sense of longing to come home. And since the moment I left the island, I always felt like what I wanted to learn and accomplish in the States, I wanted to do that for the benefit of the island of Guam. And so in 2015, that opportunity came, and I packed up my family after almost 20 years of being planted in the States and came back home, where I began my work with WestCare Pacific Islands and have been here ever since. Now in my role today, I have the privilege of creating programs and practices and policies that further the services on our island, bringing resources, training, and much needed services to our island communities, both in Guam and in Palau. So I feel very privileged to be here with you guys today. Next slide. So to kick us off, I want to talk a little bit about WestCare Pacific Islands. WestCare Pacific Islands is a nonprofit organization. We focus all our collective efforts towards our model of uplifting the human spirit in everything we do. We offer a broad array of programs and services that address gaps in services aligned with our mission. We have targeted services that support the recovery and resiliency of individuals struggling with homelessness, substance use, mental illness, and adverse experiences. We're a CARF-accredited agency adhering to the highest standards of care in our community. This is important to us, not only in setting the bar for our practices and procedures, but it also communicates to our clients that we are trusted organizations that puts their voice and choice first. We're the second nonprofit in Guam to be CARF-accredited, and the first nonprofit with an accredited adult outpatient program called Uplift Counseling Services. Now, WestCare Pacific Islands, next slide. WestCare Pacific Islands is actually part of a national organization called WestCare Foundation. We span 17 states, territories that include Guam, Commonwealth called Puerto Rico, the US Virgin Islands, and the Republic of Palau, which is under our umbrella, and the Dominican Republic. WestCare Foundation and its family of nonprofit affiliates began in Las Vegas, Nevada in 1973 as a small organization called Fitz House, which eventually became WestCare in 1998. It was a small treatment program for men who were struggling, and it established a residential program in Las Vegas, Nevada. WestCare then branched out, and through its entities across the nation and in the region, it has a vast continuum of services from inpatient residential treatment programs for a variety of persons, including pregnant women, people who are coming out of incarceration, etc., to medically assisted treatment, to harm reduction programs, and to youth and family services. WestCare Pacific Islands is an affiliate of WestCare Foundation, but all of our services are really driven by our local community. Now, I can't talk about WestCare being established in Guam without referencing our work prior to WestCare coming as its own organization. The relationship really began with Sanctuary of Guam and under the direction of Sarah Thomas Nanadog, who is my predecessor. And if you're there, Sarah, hi. It was through a relationship where Sanctuary was looking to establish its first residential treatment program, Sagan Nahomdo. WestCare provided the TTA and came out to Guam to meet all the stakeholders and assist Sanctuary in whatever capacity it had to establish the program. After that, WestCare established here in Guam with its first program being a youth prevention program targeting young females at Gora housing sites. It also absorbed the Guahan project, and these were the two projects that really got the wheels going. Since then, we have expanded to over 8 programs covering a broad spectrum from emergency housing services to behavioral health. Seeing the need throughout the Pacific region and in our work with clients, WestCare Pacific Islands established its second location in the Republic of Palau in 2015, where we continue to execute needed services to the Palauan community. We're really excited about our work in Palau. We started off as a youth prevention program, but have now established a resource center and a tutoring program, and are currently in the works to develop a domestic violence program, the first of its kind in Palau. And so growth in the region is really important to us and is part of our strategic vision. Through our regional work, we're committed to bringing new resources to the island through services, funding, training, and community awareness. Next slide. In terms of our service array, we can categorize that in 3 different sectors. The first is veteran services, the second is behavioral health, and the third is youth prevention. As mentioned, these services span an array in the continuum from prevention to intervention. They cast a large net in terms of the types of populations we serve. And all of our services are delivered in a dynamic, fast-paced, client-centered, and culturally attuned approach. Next slide. Under the umbrella of our veteran services, we have the supportive service for veteran families. And many of you may know this program because we work a lot with the other agencies to serve homeless veterans. It's a rapid rehousing and homeless prevention program providing case management and temporary financial assistance to veterans. We work with veterans who are at risk of homelessness or who are literally homeless. We get them housed pretty quickly into an emergency shelter placement and activate our case management services to really create a housing plan where they can provide a pathway to permanent housing. In addition to that, we have the Emergency Food and Shelter Program, which really captures those veterans who fall through the cracks. They may not qualify for the SSVF program for one reason or another, and they're automatically referred to Emergency Food and Shelter Program through our organization. We provide similar services in that we have temporary financial assistance for emergency shelter, homeless prevention, and homeless prevention really means that we're helping to sustain the housing that folks are currently in by providing things like rent that might be in arrears, housing, power, and water, so other utilities. We also have a veteran pantry, which is emergency food supply for those veterans who are in need. The third program under our Veteran Services umbrella is a permanent housing program for veterans that is in collaboration with GORA. We currently manage 5 units up in Jigo, where we have families who are in stable housing, who continue to get light touch case management, and who we help problem solve when issues or any threats to their permanent housing come into play. We're able to get them back into our other services and make sure that those housing placements are sustained. Next slide. Our second sector is our youth prevention services, and this is the fun, lively services. We love the youth prevention services and the workers because they are all super energetic, as they should be in their approach with youth. The first program we have is the Thrive Coalition for a Drug-Free Dedido. It's a 12-sector member coalition that is focused on decreasing the use of alcohol, marijuana, and tobacco and vaping amongst youth grades 7 to 12, specifically in the village of Dededo. The 12 Sector Coalition is really made up of various organizations, community stakeholders who include GPD, Guam Department of Education, local businesses, the mayor office. They're all actively involved and really passionate about keeping Dededo a drug-free and alcohol-free area for youth. They have engaged in many projects that we're really proud of, the first being a needs and capacity assessment in the village of Dededo to look at the trends of use amongst the youth. In addition to that, they've engaged in a village cleanup. And if you've ever driven by Dededo Payless, right across the street, you will see a big mural. It says, "Life is Malik." That was a Thrive Coalition project. And it was actually really amazing to see Kathleen Tolosa Uggan, who is the coordinator, really pulled together a handful of youth in coordination with OPAIC and did youth empowerment workshops. And as part of those workshops, they created this mural. And so we're really proud of the work that they're doing there. Most recently, we were awarded the Miracle Walks grant to revitalize a green walkable area in the village of Dededo. And so the coalition is actively working on that. Malik Natla is also a substance use prevention program with the focus on providing evidence-based workshop to youth and also engaging a campaign, a social media campaign to spread awareness to both parents and with youth on prevention strategies. Next, we have the Ilin at Lahu program, or My Life, and that really focused on the reduction of teen adolescent pregnancy. It's a school-based prevention education program that equips youth with the skills to make safer choices and address barriers to sexual risk prevention. So we go into the schools and we work with them to talk about risk and protective factors. We also, through that, have a partnership with Manyelu to provide for mentoring services as part of their participation. Lastly, our newest program, STEER, is a substance use prevention education program that really focuses on the risk of communicable diseases such as HIV, viral hepatitis, and STIs as part of a risk factor of substance use. And so it creates that linkage and provides education to youth and young adults. We also engage in community outreach to raise awareness of these risks. We have public awareness campaigns as well. We provide testing, and we also provide free condoms to encourage safer sex practices. Next slide. Finally, it brings me to the behavioral health component of WestCare Pacific Islands. We started with Uplift Counseling Services in 2017. We provide adult substance use disorder and behavioral health counseling, and we provide these services mostly in contracts through the Judiciary of Guam, U.S. Probation Office, and GCC. So right now we have an array of services that we're providing in the community. All of them are CARF accredited, and we just received the CARF accreditation for Uplift Counseling Services, which we are really proud of and excited about the work that we do as we continue to see this portion of our organization grow. And we're going to talk a little bit more about Malik Naha'ani in depth, but based on our behavioral health capacity in establishing Uplift Counseling Service since 2017, we thought to expand this entire category of behavioral health services by offering a youth program. And so what we have currently is a youth trauma treatment program that is outpatient and community-based with a focus on EBPs and treating the symptoms of trauma and its related disorders such as anxiety and depression. And we're going to kind of shift a little bit to talk about what this kind of looked like and how Malik Naha'ani came to formation. Next slide. So I talked a little bit about Uplift Counseling Services, which really set the groundwork for us to start the Youth Mental Health Program. Building upon this behavioral health capacity, when we established our internal infrastructure, which was extremely important. So we were able to get that together as an organization to be able to deliver behavioral health services. It helped us to connect with community partners, which really set the stage for WestCare Pacific Islands to begin to engage in other types of programming and extend out these services to different populations. In addition to that, our community partners and stakeholders, we often meet regularly with them in our other programs, whether it be through SSBF or through some of our school-based work, had continuously communicated the need for more access to behavioral health services for youth. And it's this feedback from our partners, including the schools where we had our prevention programs, where counselors would often say, hey, we've identified these kids, you guys provide these great prevention services, but do you have counseling? And so with the capacity that we built in behavioral health through Uplift and the need that was expressed from our community, we combine those two perspectives to apply for SAMHSA disaster response grant and created Malik Naha'ani, a school-based mental health program. Next slide. And so school-based mental health services are not a new thing. School-based mental health services have been in existence for decades. And there have been a variety of approaches that have been tried and true across the country. Those approaches range from school staff taking on the primary roles of delivering it all within the district, to community partners such as community-based mental health agencies coming in and providing those services, to full-fledged community health clinics providing these services. And community health clinics, for example, really takes a holistic approach in that it really is a clinic embedded in a school where students have access to medical professionals such as a doctor, a nurse practitioner, physician assistant. They can get checkups, immunizations, etc., and mental health professionals where they can get counseling right there on site. So these types of different school-based models exist throughout the nation, and they are extremely prevalent. Just as an example, currently, there are over 2,000 school-based health centers in the United States that provide accessible, effective, and integrated prevention and intervention supports to students and their families. Further, it was important for us to look at these models and determine how we were going to implement this in Guam. School-based counseling has many great outcomes. Behavioral health issues, as we know, largely manifest during school age, and providing support to youth in a school setting allows for a greater chance of behavioral health care usage for them because we're meeting them where they're at. The presence of mental illness in children and adolescents, as we know, if not properly diagnosed and treated, increases the likelihood of significant health and behavioral health issues for them as adults. Yeah, according to a recent article by the U.S. Department of Health and Human Services, approximately 75 to 80% in need of mental health services. Of those who do receive assistance, vast majority, about 70 to 80%, receive those mental health in schools. So what we know is that access to school-based mental health services improves physical and psychological safety, academic performance, social emotional competence, overall stability for children. The movement in the field and implementation is to establish a comprehensive school mental health system aimed to promote well-being and socio-emotional health for all students and staff while supporting those with the most mental health challenges. And that's important because that's a two-pronged approach. And we'll get into that when we start talking about the model. But it really is to make sure that mental health is supported for all students and those students who need it the most. The approach really relies on a strong working system between educators and school-employed mental health professionals, such as school psychologists, counselors, school social workers, in partnership with community health and mental health professionals. The prevalence and effectiveness of the service delivery model is evident, so much so that as we see currently, the current administration nationally, President Biden is sinking a lot of money into school-based mental health and youth mental health overall because of the pandemic. And so for us, when we were engaging in building this model, it really was the first of its kind to be implemented by a nonprofit organization, embedding themselves into a school and engaging in a comprehensive system. Next slide. Before I go on, is my internet okay? Because I just got a message about that.
There may have been like a second or two where we didn't hear like what you were saying, but it was just very, very short.
Okay, so we're on track.
Mhm.
Okay, great, thank you. Next slide. So in 2009, there was a grant that became available to establish a school-based counseling program through STEMSA. And in doing so, again, I talked about uplift and our capacity and the feedback from our staff. I thought we should really go for this. We went over all the reasons why school-based counseling works. And so I got with Guam Department of Education Superintendent and Nadine Cepeda, who is a lead school psychologist with Student Services, and we discussed what type of model we wanted to develop as we were creating this grant. And in building the model for Guam, we aim to develop a comprehensive school mental health system built upon a multi-tiered system of support. This type of system addresses mental health and wellness both universally and in a targeted approach. This type of system is meant to be integrated with the school's existing intervention hierarchy. So currently in schools through, I believe it's positive behavioral intervention, they have different tiers in which they identify students at risk. The multi-tier system of support provides different levels of mental health intervention at each tier. So at tier 1, we really have the focus on skills which benefits all students, what we often refer to universal strategies. So this could be, educational groups that focus on skill building, that talk generally about mental wellness, and that really target protective factors. And this could be delivered across every school class. It could be delivered in a character education or health education class. Tier 2 really looks at the identification of at-risk students through screening and assessment. We identify early intervention through brief counseling and other treatment modalities, both in individual and in group sessions. So these are looking at kids who sort of raise up to that next level and who might be demonstrating some symptoms, but they're not as severe as tier 3. Tier 3 supports really are for students who need the highest level of support. Their mental health impacts their daily functioning, and there's more need for intensive services, and these students often have high acuity levels. So as you see, based on the tier model, interventions become more frequent and more services may be needed to increase functionality or stabilize symptomology as you go up the tier. Next slide. The collaborative efforts in a multi-tier system of support between school personnel and community partners is paramount to the successful outcomes of the model and ultimately the client served. In the model, each player has defined roles and scopes. If you observe the two triangles, the roles of the community provider and the school staff change as you level up and down the tier. In the first tier, there's minimal community partner involvement. It really is we're more a part of the school community. We consult on strategies generally, and the very presence of a mental health community partner in the school helps to raise awareness. In tier 2, mental health professionals begin to take on more interventions directly with students through individual and group sessions. With these students, we often triage students who are in need of support, possibly make referrals, and coordinate with school staff. We advise on strategies for early intervention and work with other support staff to implement them, whether in the classroom or individually. In tier 3, mental health professionals really take these students on. There's crisis intervention, intensive therapeutic support through individual counseling, family counseling, wraparound support, and close coordination with the schools. On the other side of the triangle with the school districts, you can see that in tier 1, most of the interventions are coming from the school level. And as you go up the tier, they become less and less involved in the direct treatment of the clients and the students. And really, it becomes more about the partnership and collaboration between the school district professionals and the community mental health providers. Malik Naha'ani was built on this model in collaboration with GDOE on this type of approach. Student services existed in the schools, yet we knew that their involvement across the school district stretched them thin and really couldn't meet the full needs of the students and the schools that were really struggling. Fortunately, in my position, I had experience with this model, the multi-tiered system approach, through a middle school support pilot project in Seattle. What that looked like on an everyday basis is that our community organization embedded a master's level care coordinator with clinical skills in the school, and we functioned almost as school staff. We provided levels of support based on the tiered system, providing crisis intervention, connection, wraparound services, and individual counseling on the ground. We were often called on to consult on really difficult cases and worked with, people such as CPS workers, foster parents. We advised on even, disciplinary referrals, etc. So with that experience, the program that I worked in, we really did see great outcomes. We saw an increased access to services, reduced symptomology, and the best part about this model in working with community-based providers is that we have a rapid response to the needs that come up. So the SAMHSA grant brought together this experience and Guam's current capacity to really deliver Malak Naha'ani.
Okay, and that's back to me. Thank you, Age. So basically, Asia just really gave you a breakdown of what a school-based model looked like and how we could implement it and kind of in those early planning stages. And she also touched on the example that of the program she came from in Seattle. So I want to kind of bring that home and just demonstrate that the school-based model can work nationally, but it also works within our region. And so a huge benefit of being a grantee with SAMHSA is being able to meet with other grantees throughout and its territories. I was able to participate in regional monthly learning collaboratives that included grantees from Hawaii and Panama. And so our sister island, Saipan, has a school-based program called Project TASA. And in its first demonstrated that even with the challenges from the pandemic, school-based services can work with our island community. This program operates from within its public school system and works on a tier level, as Asia beautifully broke down. And as we shift our focus to our community here in Guam, WestCare hopes to do the same thing here. And based on the research and as Asia previously discussed, the school-based model does work. Next slide, please. So this brings me to the start of what would be WestCare Pacific Islands Youth Behavioral Health Program. In April 2020, we were elated to find out that we were awarded an 18-month disaster response grant from SAMHSA. So that's the Substance Abuse Mental Health Services Administration under the Department of Health and Human Services. And so in keeping with the practice of giving our programs Chamorro names, as you may have noticed, as Asia was giving the overview, the program was called Malak Naha'ani, or loosely translated to mean bright futures. And so I'm aware that it means happy day, but name described to a T of what we wanted to promote for youth, that challenges of adolescence, coupled with experiences, there was still hope to heal and look towards a brighter future. The program would be a school-based model, and with close collaboration with GDOE, its Student Support Services Division with Nadine Cepeda, Malak Naha'ani would be integrated into the schools, where the clinicians would provide counseling on site and have the ability to respond to crises on campus. So planning meetings were held with myself, Asia, and Nadine prior to the start of the school year in 2020. Much of what we discussed was how Malak Naha'ani would fit from identification to referral to treatment. Identification of students who would benefit from services would come from school staff, from the faculty, administrators, and the school counselors. And then the school counselors would then make those referrals to Malak Naha'ani, and then our clinicians would take it from there. You may ask how Malak Naha'ani is different from support services and behavior services already embedded within our school system. So one, Programs like the emotional disabilities program that I mentioned that I worked for a long time with, they're under the umbrella of special education. And so that requires assessments for eligibility. And then ultimately, any child that's eligible would have an individual education plan. SSD, or the Student Behavioral Health Program, has its school counselors and psychologists assigned to all the public schools on the island. And so in order to not duplicate services, Malik utilized the tiered approach described. Based on the screeners that were used by the should a student score on a tier 2 or a tier 3 level, then those students would be the ones to Malik Nahani. Next slide, please. And so continuing with planning and implementation, WestCare wanted to make sure that the processes were aligned with each school, and that was accomplished by meeting with the school administrators collectively. Then the school-specific meetings to include those administrators, the school counselors, and then our Malik Nahani team. The intent was not to take over or duplicate any services, but to be where we were most needed. So in this planning phase, it was determined that Malik Nahani was needed at 3 specific school sites. And those school sites were Ukudu High School, SBLG Middle School, and Beneventi Middle School. And how did we come to choose these 3 schools? Well, it was really based off of the number of disciplinary referrals reported for school year 2019-2020. So at the time, Ukudu High School had 1,251 disciplinary referrals. SBLG had 794 disciplinary referrals, and then BMS had 902. It's important to point out that these numbers were provided from the GDOE central office, and the types of disciplinary referrals were not. So that could just mean that, it could be a broad range of these infractions. It could start from a minor offense, such as being out of uniform, multiple times, to a major offense, such as being involved in a physical altercation on campus. So we didn't really have the specifics of the kinds of disciplinary referrals. We had the numbers. And so now that we had the 3 school sites that Malik Nahani would be based at, we continued working with the school administrators and the school counselors. We also held monthly meetings to provide updates on the referrals received and the clients we worked with. And then clinicians were also afforded the opportunity to sit in on the child study teams, because if you're not familiar with how it works, there's a child studies team that happens prior to making any kind of referrals or making any major interventions, because you have to kind of look at what's been tried, what hasn't worked, and what has worked based on the strengths and the weaknesses of the student. So it takes a lot of planning and coordination. And so we were able to sit on these child study teams with parent guardian consent, of course. And it was an effort to bridge the communication and also act as a sort of warm handoff, because once we received the referral, then Malik Nahani would already know some of the background. And the students wouldn't have to repeat themselves, and the parents wouldn't have to repeat themselves too much. Malik Nahani also conducted outreaches at these school sites. So we presented at faculty parent meetings, we set up resource tables during lunchtime. We were talking about mental health to different grade levels. And we also participated in summer school programs that highlighted social emotional wellness. Next slide, please. Okay, so I'm more of a visual learner, and so much of my time spent describing the process can better be described using our program model for the school-based service. So one, we would get a referral to our school-based clinician, and again, it would come from the school counselors. And Malik Nahani had 3 school-based clinicians, and each school-based clinician was based at one of those 3 school sites. And they were master's level licensed eligible clinicians. 2, then they would be screened for services, one of 2 ways, utilizing screening and diagnostic tools. And then, so based on those tools, like we see right there on the screen, it says for the initial global assessment, it was a screening, brief, intervention, and referral to treatment, also known as the SBIRT. or a targeted assessment. So again, using the expert, but we also had assessments called the youth self-report and the child behavior checklist. The child behavior checklist was more of the parents or guardians' perception of the struggles that the youth was experiencing. We also used a mental health status exam and then a biopsychosocial. And as you see by the asterisk, that just means that we didn't do any of these things in this process without parent or guardian consent to do so. So then in the next row in the model, that was the array of services that we would provide. So we would provide crisis intervention. And if they were at the highest crisis level, then Guam Behavioral Health would be contacted and we would make that linkage. And then we connect with parent and follow up with school. But we would still remain, the student would still remain in our program, and it would be worked out with how we would partner with Guam Behavioral in order to provide that individual service component. And again, with school-based services, we were going to be on site and we would be able to respond to crises that were at the school and be able to take it from there. We also provide individual counseling, and so the EBPs we use is cognitive behavioral therapy, motivational interviewing, and then cognitive behavioral intervention for trauma in schools. That's also known as CBITS. It's a group intervention, but it can also be used individually. And it's a therapeutic group. They kind of break down the experiences of trauma that the youth are experiencing, and then they follow up with individual sessions embedded within the entire time of the group, because things that are being shared are so heavy that we have to kind of do some check-ins. And then we also had group intervention, and we utilized the support for students exposed to trauma, or SET. And so that is if you want to take CBITS but make it less clinical and more of maybe psychoeducational, or just a little bit less talking about trauma, then that would be what our SET group would be. And that was run by our youth service specialists. So along with the 3 school-based clinicians, we also had 3 youth service specialists that worked in tandem with the clinicians at each school site. So we had a team of 2. And so that was kind of the partnership that we worked with. And then not mentioned on this slide is we also had a research assistant. So if, in case some of you guys don't know, whenever you are awarded a grant or any kind of contract, you need to provide data on how your program is working. Are we making any kind of progress? And I will always say for myself, I'm not good with data, I'm not real good with research. So thankfully we had a research assistant in our program that was able to kind of handle all of that, and who worked with our evaluator with the WestCare Foundation to make sense of all of that. And then we also had our administrative assistant, who was truly the backbone of this whole program and really handled all of the supporting services and needs that we needed. And so our youth service specialists were bachelor's level. And so you could just kind of see the continuum of the education and experience, and we really, really capitalized off of that. Next slide, please. And then, of course, the pandemic hit Guam in March 2020. And it soon became unclear whether or not schools would be opened, how our school-based services would look. So the irony is not lost on me that a disaster response program that was aimed at helping kids work through trauma as a result of natural disasters we were now hitting a snag in the road because of a global pandemic. But as we always do, Malik Naha'ani continued with implementation. We continued adapting our services to meet the challenges that were presented by the pandemic. Next slide, please. And so I talked a bit about how the impact of COVID on Malik Naha'ani, but I wanted to shift some focus just to the impact of the pandemic on everybody, most especially our youth. And so I'm sure I speak for everyone in this virtual Zoom room when I say that COVID has truly tested our mental strength, our level of resiliency, and our ability to adapt to rapid change. But how has it impacted our kids, our adolescents? U.S. emergency rooms have seen a surge in kids with mental health crises, including suicidal behavior, depression, and eating disorders. Pediatric mental health therapists are scarce in many areas, and kids were often waiting months for outpatient treatment. In 2007, there was the Public Health Advisory. U.S. Surgeon General cited research showing that depression and anxiety symptoms doubled among youth worldwide during the pandemic, and expanding school-based programs was among one of his recommendations. He called the nation's youth mental health a crisis. It was a crisis. I mean, think about how heavy that word is. And then the American Academy of Pediatrics was among the groups that recently made similar recommendations in declaring children's faltering mental health a national emergency. So that's just kind of a broad picture of how our youth were being affected nationally. Next slide, please. And so let's take a look at how at our island and the effects felt from COVID. And so as you can see on the slide, a survey by the Governor's Youth Advisory Council showed that over 83% of 1,300 plus students were concerned about their mental health while attending class online. And one high school student reported that anxiety levels in students are up. Students were experiencing higher levels of depression and other negative mental health effects. So seeing the data and working with youth at these 3 school sites helped ignite the process for Malik Nahani to kind of evaluate how we could increase access for those that were hardest to reach, specifically reaching the kids who are not in school. As Asia mentioned, studies showed school-based services increased access, but because the kids weren't in school and being identified and screened and referred, we as professionals were inclined to go back to the drawing board and begin troubleshooting, if you will. Each step of the way when building a brand new program, a major part and looking at each point in the process and seeing if it can be improved. And COVID caused us to have to think quickly and respond accordingly. So by looking at the impact on a national and local scale and seeing how most kids last school year opted to remain with so the clinician finding that the significant space was being isolated, disconnected from their peers, we began to reevaluate if these were concerns at only 3 of the island schools, how many more kids are out there struggling? And so having said all of that, Malik Nahani's school-based program ended in December 2021. And since it was a disaster response grant, most grants of this type are often short-term. Even though the grant itself ended, we did not stop and looked to move Malik Nahani to a wider scale. You know, and as I mentioned, we did a lot of planning and we were so excited about doing a school-based program, but you know, as we all experienced it, not a lot of the kids were in schools, and I happened to be at Okudu some days when it was still at the height of the pandemic and kids were still slowly returning, and there was the model of either you can do in person, you could do online or hard copy. And I'll tell you, a lot of the classrooms maybe had 3 to 4 students. So being a school-based program and relying heavily on the data and you know, the experiences that the staff and the faculty and the teachers had in noticing these behaviors, that there was a gap because most of the kids were at home. And so we couldn't really reach them. And so as much as we really wanted to be on the ground and work with the kids that we could have, we needed to move to try to reach a bigger range of students. Next slide, please.
That being said, we acknowledge the shortcomings of the school-based program, given the time and the place that we're in. In 2021, a grant opportunity came up through SAMHSA again, a 5-year grant that was an opportunity for us to establish community-based trauma counseling for youth. And the goal was taking the experience of Malik Nahani, and at the time we were still implementing services, combining that with community-based service to extend our reach, that we would be able to capture those students and families who are at most risk in the community. At the same time, our Uplift program was working closely with Guam Behavioral Health and Wellness to provide services to offload some of the clients coming in through the crisis call, the crisis line. And through that relationship, we really understood the uptick in the need. It was evident. We knew that if adults were struggling with issues of depression, anxiety, suicidality, drug abuse, and family violence, what more our youth who are in these environments or witness in these environments and do not have the option of reaching out because of the isolation. So with this in mind, and along with our lack of reach in the school-based model, which we're really bound to, we endeavored to apply and receive the grant. We moved to expand our services to provide the community-based trauma treatment. And community-based behavioral health care is a common delivery system since the late 1960s. It really is a delivery of services, and it can be done through government or county organized operations, as well as private nonprofits and for-profits. Community-based services include counseling, mental health counseling, substance use treatment. There's a whole variety, residential treatment, a whole variety and spectrum of services under the community-based umbrella. Community-based services are typically funded through a patchwork of sources, including Medicaid, Medicare, county, state, and federal programs, as well as private insurance and self-pay. Now, here in Guam, a community-based nonprofit outpatient program is something a little bit different than what we're used to in the nonprofit sector because of the structure of the payment process. So in Guam, with the exception with specialized services for substance use disorder treatment, such as residential counseling, for example, through Salvation Army or Sanctuary, Guam Behavioral Health and Wellness Center really is the state agency and the main provider of mental health services for our youth today. And so with this in mind, we had to kind of figure out how we would garner sustainable funding, because we knew Guam Behavioral Health and Wellness Center, and in our collaboration with them, the need is so great, right? And the experience of the families have shown that there's more need out there than what we can serve. And so we utilized this grant as an opportunity to meet that need. And we are one of the few nonprofit organizations in Guam to provide this outpatient services. I will make note, though, that it is a common practice across the US that community-based mental health and behavioral health services across the continuum from residential to outpatient are delivered primarily by nonprofits. So for us, this is something new, and we're breaking into a system that I will say for our partners at Guam Behavioral Health they're super supportive and ready for another community partner to come in and help with the communities, our communities in need. Next slide.
All right, thank you, Age. And so as Asia mentioned, as grant season approached, WestCare began to look for funding opportunities that would enable Malak Naha'ani to operate as an outpatient program. And so in February 2021, we applied for the National Child Traumatic Stress Initiative, Category 3 or NITSI. And this grant looked to fund programs to provide and increase access to effective trauma treatment services for children and adolescents and their families. And so I'm happy to announce that we were awarded this 5-year grant in September 2021. You may have seen me on the media talking about this. So if you haven't heard, we did get the 5-year grant. And so implementation happened in January of this year. This award propelled us even further to begin operating as a community-based outpatient program. And as mentioned, when we were starting up Malak Naha'ani, we began with a planning phase. And so we had to kind of do that again as we transitioned to community-based. And so we started to think about the existing programs and organizations that we already partnered with. And some complain that Guam is too small, right? But when it comes to feats like this one, I have to tell you, being part of a small community is truly a blessing because all of us are in the helping profession and we've been working with each other for years, and it just makes it a lot easier to reach out and garner support when we need it. So we planned a stakeholders meeting at the end of last year and invited a few organizations that worked with youth, such as Cassidy with Guam Behavioral, more specifically with Isa Maguenta, Sanctuary, CPS, Erica's House, and Vero. And so we did the same thing we're doing here today, but a more condensed version. So talking about what we want to do, talking about our services. We talked about our evolution towards community-based services and how each of these organizations could see us fitting into the processes and services that they already had in place. Again, we're not looking to reinvent the wheel, but more so to be an additional resource for the clients that they served and their families. So it's safe to say that there are a few nonprofit organizations in Guam that provide behavioral health counseling. And so Malik Nahaani just hoped to close that gap. Next slide, please. Again, I'm a visual learner, so it's a bit better for me to illustrate this. So from the stakeholders meeting, we continued moving forward or navigating forward. And so we held follow-up meetings with those who attended the stakeholders meeting, but more on an individual basis to really dive into their practices and their procedures and carve out a place for Malik Nahaani services. And I will share that our shift has been met with enthusiasm just because it is an added option for youth and families. And again, here's a visual flow of that process and how it looks when you make a referral now to Malik Nahaani. And so we start out by receiving referrals from community partners and or parents or guardians. And then from there, we do an eligibility screening, and then we proceed to do the intake assessment. And so the EBPs that we selected for this grant are the cognitive behavioral, back to the assessment, is the Connors Comprehensive Behavior Rating Scale, the UCLA PTSD Index, Child and Adolescent Self-Report, a mental health status exam still, and the biopsychosocial. And so after intake, we look at what services would best suit the client. And so we still offer individual counseling. We still use cognitive behavioral therapy, motivational interviewing, and now we utilize trauma-focused cognitive behavioral therapy, or TFCBT. We still do group intervention, but we shifted from what I refer to as CBITS and SET in the school-based setting, because those group interventions were specifically for school-based models. And so now we use Seeking Safety, which couples trauma as well as substance use, but you don't have to have a substance use disorder in order to participate in Seeking Safety. And we also offer family counseling as needed. We still assist with crisis intervention, so it's the same thing. We triage, we do an assessment, we provide linkages to referrals. We follow up with clients, parents, and schools, and our partners. Again, what is the difference? How does Malik Nahaani fit? So again, we intend to be an additional resource and strengthening our partnership. So for instance, for us, youth do not need to have a diagnosis to avail of our services. However, we do not do medication management, nor do we do wraparound services. So that's where we would, knock on the door of our neighbor, or our partner over at Guam Behavioral under Cassidy and say, hey, we're working with this student or this youth and their family, medication is an issue. How do we connect them? Or we're thinking that the family's going to need some more services and it's not just, our youth. How can we get them connected to other services? So really it's capitalizing on these partnerships that we have. And so that's kind of how we look to fit into all of these other community partners and all of these services, because we have a great dynamic and we have a good amount of people who work in these youth serving agencies. And so it's just about being able to make these connections. Next slide, please. So a common question on any type of journey is usually, are we there yet, or where are we now? Well, yes, we are here, and this is where we are. So since implementation in January, Malik Nahaani has received a total of 18 referrals. The number on the slide says 16, but just yesterday we received 2 more. That's just kind of how quickly we're working over here. We currently have 18 active clients, and we are seeing increased requests for family counseling. We're seeing an uptick and demonstrating that the need is there, and it further illustrates that there was a need for this service and WestCare's goal to fill this gap in accessibility to services. Where are we getting these referrals from? We're getting them from our community partners, such as DPS, the AG's office, from our schools, and nonprofit agencies such as Sanctuary. And we do continue to do outreach services. And so we've had 7 so far, community presentations. We've been to Southern High School. We've been to Career Tech High School in Agate. We've been to Untalan Middle School. The clinicians did a virtual webinar in partnership with Manyetlu. We're getting requests from Agata to assist in providing some mental health workshops. We presented to the National Guard and their families and their service members. We met with Sanctuary and their case managers. We also had meetings with GDOE and all of their administrators to talk about our program and our services. Thanks to Nadine for setting that up. And we also met with the Drug Offender Reentry Program, or DOR. And so even though that works with adults who were offenders, who had substance use disorders, it was important for us, and they saw an importance in it as well, to hear from our youth program, because they may have kids or they may have family members who they know would benefit from our services. So that's where we are now, and we're moving through at a fast pace. We get about 2 to 3 referrals a week, and we're just definitely pushing through. And I think it's demonstrating that there is definitely a need out there for another option. And so I will go ahead and hand it over back to Asia. Next slide.
So our vision for the future, unfortunately, the school-based program ended. We would have liked to see a continuation, but as all nonprofits are, we're challenged with sustainable funding. Our vision is to really grow our youth behavioral health program to eventually incorporate both the school-based model and our community-based outpatient services. We will seek CARF accreditation on our next round to ensure that our programs are meeting the highest standard of care as designated by the CARF Accreditation Council. We will be looking for expanded funding both locally and federally so that we can sustain these services. If there's anything that we've learned is that these services are needed, and they are needed to a scale that's greater than most of us really know. It's kind of one of those, if you build it, they will come. That's been the situation since the establishment of our community-based program. As Bev said, she might get off this presentation and have 2 more referrals waiting. So the need is out there. Lastly, our goal in everything we do at WestCare Pacific Islands is to deliver services that are relevant, meaningful, and make a difference in the lives of the person we serve. In closing, really just reflecting on all that we presented today, our key takeaway from our experiences is that we know as peoples of the Pacific that tides always change. Yet we as a people will always sail forward, navigating our way toward a brighter future for our youth and our island. Next slide. So we thank you for joining us today and for learning more about WestCare Pacific Islands and our program Malik Naha'ani. And we are just so grateful to be with you all and are happy to take your questions.
Hello, I have a question. So how would someone in need of these services go about contacting WestCare, or is it only through referral?
So it doesn't have to be, through a referral form, although we do have that. It just really starts with a phone call, with an email, anything like that, just asking questions and seeing if our program is the best fit. So really just reaching out to us and starting from there. And I can put our brochure on the chat if that would be helpful for everybody.
Please do. And thank you for answering my question.
Of course.
Hi, ladies. This is Rosemary Camacho. I think we've had some clients in common through your school-based program. I'm still with the Healing Hearts Crisis Center on a part-time basis. Been there forever. How do you have a way of addressing transportation issues of getting clients to you? Because that's in rural social work, that's always a problem. And that's a problem we run into with the services we provide through Healing Hearts. Although we do have the option to do virtual sessions, that's not always feasible. I actually hate doing virtual sessions because it's really hard to keep a child's focus, especially when their brothers and sisters are running around the room. So do you have any ways that you've broken barriers to transportation
Hi, Rosemary. I can answer that, and if Asia wanted to jump in, she can. It's the same thing that we experience as well. You know, I think just going back to the school-based model, the accessibility was there because the kids were going to be at school, so the burden of transportation didn't weigh so heavy on the parents. However, during COVID, a lot of the kids that we saw that did not go to school and were doing it online, their parents opted to bring them. And, you know, we did provide, because we understood the struggle, we were able to provide, you know, gas cards to help them. And now, because our services are primarily at our office and we no longer do school site-based counseling, we do have the availability to use transportation in order to do that. And we use that as a last resort, but we do have that option. And also we do treat it on a case-by-case basis. So, you know, really looking at if transportation is truly the barrier that is blocking or preventing this youth and his or her family or their family from accessing this much needed service, then we'll work with them to figure that out. You know, and also working with some of the residential organizations such as Sanctuary, you know, we even offered that our clinicians could go there and do some services or do some group services. So we're just kind of going and figuring it out, but we do have the option of offering transportation if it's needed, but we try to explore other ways as well.
Thank you.
You're welcome.
Hi, good afternoon.
Oh, go ahead.
This is Naomi Sanchez. I'm with Guam Legal Services. I'm an advocate here. Are you able to walk us through your initial eligibility screening once a referral is received?
Yeah, so basically it's, how do I put it? I don't want to say everyone that comes through is pretty much eligible. What we do is we do ask certain questions. You know, we have to fit, and which I didn't mention, but they have to fit within the age range. And so we do provide mental health counseling services to middle school and high school students. So that 11 to 17 range. So that would be the first question we ask. I also wanted to highlight that our program is a no-cost program, or meaning that it's a free service. So there's no cost to the family, so they don't have that financial burden. But we really just look at the age range to make sure that it's appropriate for our program. And also just we just ask basic questions of what the behaviors are, what are they experiencing, and then we take it from there, and then we schedule an intake. And so the intake is where we do the assessments and see how they score. So depending on how they score, that again will make the determination if it will be an individual weekly counseling session, or if it would be more of, because we've been getting siblings, so it's more of a family counseling intervention would work best, or if it would be more of a monthly thing. So really it's just making sure that, you know, they're within the age range and the level of struggles or concerns that they're dealing with. And then we really kind of look at it more when we do the intake to see what services or what kind of service they would benefit from.
Thank you so much.
You're welcome. And I did put the brochure in the chat. So it has our contact number as well as our website as well.
Hi, ladies. I have a question.
Hello, go ahead.
Now, I'm new to CPS. Now, let's say I receive a referral and then I find out that the minor is also attending one of your programs. What disclosure form will I use in order to get that information that I would need to, I guess, utilize for CPS?
That's a great question, Andrew, and thank you for asking that. So it just like you guys would have your release of information forms or your ROIs, we have the same as well. So when we do get clients or kids that come in through the program and it's mentioned that they have a CPS social worker, we do have a release of information form that pretty much outlines who family would like us to talk to and the extent of that information, even the school. So say a parent refers a child and they're saying, you know, but my son is also experiencing, you know, concerns at school. and I would like you to be able to talk to the school counselor there or whatever. We don't talk to anybody unless parent or guardian signs a release of information to do so. And so even if CPS became involved in, and we've already been seeing a client for a couple months or so, we're still able to provide that release of information so we can get that signed. So that's very important to us. And it would be the same thing on your side, I believe, is if you were working with a family and you thought, you know, this child would benefit from our services, you know, you guys would follow your process in making sure that you have that consent to do so, to reach out to us, and then we would make that connection from there. So I hope that answered your question.
Okay, so if there are no more questions, thank you, Asia Ramos and Beverly Coleman, for your presentation.
Thank you so much.
Thank you, guys. And for everyone else, please join us in the main room for the rest of our NASW conference, or feel free to join the other tracks. Breakout rooms will close at 2 p.m. Before that, we have some information on CEUs. NASW will be offering 1 CEU for ethical presentation with Dr. Schwab on day 1, and 1 CEU for the cultural panel on day 2. This is separate from GLE's 1 CEU for 10 contact hours. For social work CEU inquiries, please contact Ovita Perez at naswgu@gmail.com. For CEUs with UOG, please contact uog.gle at triton.uog.edu. I will also post this info in the chat. Again, thank you for your presentation, and we'll see you back at the main room at 2 p.m.